So we're here in Copenhagen for a European meeting aimed at discussing some of the highlights of a recent Congress of the American Society of Hematology held in New Orleans. Purpose is to see what has emerged in particular in hematological malignancies and to see how this could translate in different approach to the clinical management of patients with diseases. So we have the fortune of having some of colleagues and friends here, and I would like to introduce them. Clemens Wendtner from Munich and Simon Rule from Plymouth, UK and Germany. And I would take advantage of them being here, and I thank them for being available, to ask them what they think has emerged in two particular diseases which are extremely important. One is chronic lymphocytic leukemia and the other is mantle cell lymphoma. So Clemens, would you give us maybe a short update of what you think are the key points that have emerged and how this could possibly translate in different clinical management of CLL patients?
Right. First of all, I think ASH 2013 was a little bit of CLL firework. So we have seen many abstracts, new things, phase 3 trials. First point I would like to make, we have seen, I think, some convincing data that we can achieve very nice remissions also in the elderly CLL patients. This is the majority of CLL patients using a chemo backbone, chloramicin, plus anti-CD20 antibodies. We have seen different phase 3 trials using ofatumumab, for example, using rituximab, using obinutuzumab. The most convincing data for myself, although I'm a little bit biased because I was part of this trial, was the combination of chloramicin plus obinutuzumab. It's a new type 2 anti-CD20 antibody. This will probably become the new standard in the elderly ones. Besides this, I think we have seen many data, including phase 3 data, using new tyrosine kinase inhibitors, even in a disease like CLL. This is new. We have seen data using a PI3 kinase delta inhibitor called idelalisib. We have seen data using a BTK inhibitor called ibrutinib. And we have seen data using a BCL2 inhibitor called ABT199. So we are approaching maybe an area where we will not use chemotherapy anymore. So we are coming very close to a chemo-free approach.
So you're thinking, if I may make a comment, that it's probably a turning point, this.
Yes.
Because we've been obviously managing CLL for years with chemo, and you think we're probably opening a new era where we hope, like for other conditions, that we might go towards a chemo-free.
Absolutely. I think chemo is still a point in the very young and fit ones, but this is a minority that we're aiming for MRD negative disease, so you really have to hit hard, including chemotherapy. But in the elderly ones, the majority of CLL patients, so the median age is above 70, you have to think about this. Chemo-free is the new way to go, and this includes antibodies and signaling inhibitors called tyrosine kinase inhibitors.
So that'll be the change.
Yes.
And Simon, do you think are we in a similar area for mantle cell lymphoma too, and does that emerge again at ASH, although data came earlier from
Yes,
mantle cell?
I think we're in exactly the same place in mantle cell lymphoma. I mean, ASH this year was all about CLL. There was very little on mantle cell actually. I mean, just before ASH happened, ibrutinib got a license through the FDA, so it's clearly going to be a very important drug in mantle cell lymphoma. There wasn't a lot at ASH, but there was data in some of these newer agents, another BTK inhibitor. There was data on ABT199, so very similar drugs, oral, very active, modest toxicity, which is going to certainly lend them to being incorporated into novel chemo-free regimens. There was data adding drugs into established chemotherapy regimens. I was struck by the addition of Velcade to bendamustine rituximab with some dexamethasone, clearly a very active regimen in older patients. There was data on lenalidomide rituximab, which has become very trendy, if you like, in indolent lymphomas. Very early that data, whether that's going to be as good as chemotherapy-based treatments, we'll see, but I think we're in a very similar place to CLL, very similar.
It comes to my mind, in the old days, or old, even up to today, I always used to say that key point is to make a differential diagnosis in diseases. I'm just coming to my mind thinking about the BTK inhibitors, that maybe,
Maybe it doesn't matter.
well, maybe it matters less nowadays.
Yeah.
I mean, this is ironic. I always tell everybody that we have to be very precise. Think of the leukemic mantle cell lymphoma, which is an entity in between classic nodal mantle cell and CLL. And I always say, or we always say, you have to be very precise, not a CLL. But I mean, if the BTK inhibitors are equally effective in CLL and in mantle cell, they imagine will be equally effective in leukemic mantle cell or mantle cell in leukemic phase. Although I don't know if we have any data in that specific area.
We don't. I mean, those patients tend to have a more indolent biology than the classic nodal.
Right.
But I would imagine perhaps that group would be better off with the BTK inhibitors.
There you go. Maybe we should do a study on that. That comes to my mind now.
Yeah.
Anything else that struck you in particular? Or
no, I think these trials are ongoing,
Right.
and I think what you saw with CLL this year, you're going to see in the lymphomas in the next couple of years. They're very similar trials being designed. They're very similar approaches being looked at. I think the interesting thing will be when we finally do head-to-head trials of non-chemo versus chemo approaches, because the challenge there is what endpoints you're going to use, because you may not get the responses with chemo immunotherapy are very good. When you start using chemo-free regimens, they might be equally as good, but actually much better tolerated. So we've got to be, I think we're into non-inferiority, quality of life design studies. I think that's a whole different paradigm to improving response, improving remission, not just duration, but depth of remission, which is what's been the drive for years and years and years. I think we'll have to go from there to being very much more patient-focused.
Again, that becomes a bit provocative because we always just say that ideally we'd like a patient to become MRD negative, minimal disease negative, which means a lot of treatment, obviously. And maybe, again, maybe not for all patients, but a very high-risk patient, at least in CLL, probably need aggressive treatment. But for us, it might be different. I mean, if you can control the disease, chronicize it for years and years, and patients live well with less toxicity, I think any of us would be very happy with that as physicians, and certainly patient would be happy with that. If I may add one point on this, but I think, this goes into obviously the area of defining disease well, biology applied, MRD, whatever. I think something that is emerging is the development of new technologies, because new drugs come from new technologies too. I mean, we have all these personalized medicines that we use for different diseases in hematology, and even the BTK inhibitors, because they're targeting the B-cell receptor, which plays obviously a major role in this disease. What we're seeing is now that you can use technology to stratify patients even more. And I mean, one thing that came out at ASH was, and I think it's very interesting, in CLL, was the fact that you can identify a subgroup of CLL patients that in fact have a minute P53 subclone, which I think is very interesting because so far we know that in CLL, the subgroup of patients who actually does worse, it's a group that harbors a P53 disruption. And we always say that those patients will be treated in a different way. They don't usually respond to conventional treatment. We have to go to different treatment. And if they're young enough, we try to offer them a transplant because that's the only way we could try to salvage them, because their progression-free and overall survival rates are extremely poor. And the data by ultra deep sequencing shows that you can pick up minute subclones of P53. There was an oral presentation at ASH, even to an extent of 1%, and to a proportion as about almost 6% of patient diagnosis. And these are patients who would not have been recognized because they're under the limit of detection of conventional Sanger sequencing, which is roughly 20%. Now, the important point is not to find it, but to show that appears to correlate again with bad prognosis. So in fact, broadening the subgroup of CLL patients with a very poor prognostic likelihood based on deep sequencing. And that adds up prior to treatment of almost 15% of cases, which is not a small proportion. So I think technology development, I think we'll see more of that in the future. And I think this is extremely interesting, particularly now that we have new drugs. we'll have to see the new drugs, how effective they are in the P50 disruptor, because there's great hope for that. But I think we'll have to see that even further.
Well, I think that's increasingly more important because these new drugs do work very effectively in that situation, and these are expensive drugs.
Right.
So you want to be using them in the best place rather than exposing them to expensive chemotherapy, which isn't going to work.
And you might also have to redo these kind of analysis in the area of new drugs, because the prognostic impact of P53 might then change when you have these new drugs available. But we have to clearly analyze this within controlled trials. We have to have very long observation times and things like
So
that.
it's almost more biology applied to clinical trials. That
Absolutely.
I think is a message coming out
absolutely.
always more.
Absolutely.
Because we're subdividing groups and sub-analysis. So I think that it's been a positive ASH meeting. I think important conclusions have come out. I think one conclusion that we always say is that all these conclusions come from clinical trials. I mean, we always say, because one of the endpoints of this meeting in Copenhagen is how would these inputs or outputs from the Congress actually impact the clinical daily activity? And we always say that this might take a bit more time. I mean, I think they have to be confirmed on large clinical trials. So we always insist that patients should go on clinical trials. And if we do studies quickly, then we can get responses that then can actually impact on the daily activity. So, I thank you very much for being here tonight for the Film Before You Cancer. So thank you very much,
Thank you. Thank you,
see you
Robin.
next time.
Thanks.